Ed. All right, let's do it. We will start the recording before I mess something else up. How about that? We'll just get it started. So, y'all were talking about how anxiety seems to present younger. Is that what I saw somebody write? Anxiety maybe
Uh,
a little younger.
I was, I think it was older, and we had a question about in terms of logging therapy time in the Typhon. So perhaps at the end you can address that.
Yeah, anxiety is as a class, anxiety is the most common psychiatric disorder in little people. For a singular diagnosis, it'll be ADHD probably. Those of you who are working more inpatient, you're probably not going to see kids inpatient for anxiety or for ADHD. Those are more so, if it's the primary diagnosis, you'll see that in a kind of a primary care child psych location. They may be comorbidities for a reason that a child needs inpatient care. Someone had mentioned that you see a lot of autism spectrum, ODD, bipolar disorder. Yes, absolutely. Absolutely, Kelly. More behaviorally disruptive presentations that may be a reason for inpatient care and then followed outpatient. So what we were going to talk about tonight, which now we can, and I really appreciate y'all's patience. We did ADHD last time pretty much exclusively. Tonight our goal is to cover autism spectrum and anxiety and depression, and then we're going to save bipolar, disruptive mood dysregulation, ODD conduct for next time to kind of finish it up. So we're shooting for autism spectrum, anxiety, depression. And it sounds like, Kelly, you're working with kids and adolescents with autism on the spectrum. Is that correct? Anybody else working with kids on the spectrum? Kelly is, yes. Sure, Deborah is. Okay. Tracy is. Wonderful. In Birmingham, we're fortunate to have a autism behavior kind of specialty organization called Glenwood, who provides services really across the lifespan for kids. And Sabina, you did last semester. Okay. This little graph right here to the right just shows, and it's not the newest figure in the world, but how there is an exponential increase in autism spectrum diagnoses from 1 in 150 to more recently you may have seen 1 out of 88. That's a lot. This happens to parallel changes in legislation that afforded certain educational accommodations to children with autism. So and I'm not saying that that's why that happened, but you will see as culture changes, then diagnoses change, or as medicines come out, diagnoses that medicine can help increase. So the long and the short of it is that autism and autism spectrum disorders, which is just a certain developmental disorder, is something that you need to screen for. Something that you want to be considerate of. So knowing those normal developmental speech and reciprocity milestones is and language and abstraction and symbolic thought and interactive play and spontaneous play. When you would want to really see those by, and the main one is speech. Seems to be probably the thing that gets parents to pursue a screening or an assessment considering autism spectrum has to do with delay of expressive speech, because that's pretty. ASD is more prevalent due to both better diagnosis. Kelly's saying that maybe it's more prevalent because the diagnoses are better, and maybe it's actually more common. You know, it may actually be more common than it was 20 years ago. It might be. As diagnostic tools are improved, you run the risk of more false positives as much as you do more false negatives if the instrument is maybe too specific. or just way too sensitive. But we really don't know. We don't know. We don't know necessarily. They can't pin it on a cause. But what we can say is that the incidence rates are somewhere in the neighborhood of 1 in 100, 1 in 150. That's what we're going with right now. Risk factors tend to be not only increased maternal age, but increased paternal age. Is it causative or is it a correlation? Not necessarily sure, but it does seem as though children who were born to parents who were older, to the father, the paternal parent is older. Exposure to valproates or Depakote in utero, that can increase the likelihood of a child having autism spectrum disorder. So there are some risk factors. I know, I don't know, but yes. Older father. Now, is there some third factor that older dads having kids is, I don't know if that's a biological thing. Is it, hey, I don't know. But it's a correlation that they have noted. Older moms, older dads, even more so. Over 50. So a child who was born to a father 50 or older is more likely than someone to have autism than a child whose dad was less than 50. Just think it's interesting. Other risk factors. Other risk factors are going to be a family history of traits. If you look back on the parents or uncles and aunts, you may find not necessarily family members meeting full criteria for an autism spectrum, for a moderate or severe autism spectrum disorder, but maybe what we used to call Asperger's. The DSM-5 did away with the distinction of Asperger's, which has been really unpopular, but they're really referring to someone on the autism spectrum who's very high functioning or very mild symptom presentation. But you may have the parents or relatives who were socially not as skillful socially, kind of rigid interests, very circumscribed particular interests, maybe not real socially driven, more interested in things. And the term was helpful, I think. And the Autism Society of America, they had a term, and they were very upset that that term had changed or is no longer recognized. There's an unusually high incidence of autism spectrum disorders in Huntsville, in northern Alabama, which was a big NASA location, a big engineering, science, not language, not symbolism, not feeling, not creativity necessarily. It was just a highly concentrated group of people who had particular interests in science and engineering. And as a correlation, there's a higher relative number of kids born who might meet criteria for autism spectrum. Just looking back, you may see some genetic loading. From a scanning standpoint, younger kids with autism, if you did a CT scan or something like that, would have higher volume of the frontal lobe. And usually we think disorders, psychiatric disorders, you think, cortical thinning or frontal lobe is smaller. Not necessarily in the case with kids with autism. There may be actually larger than average size of the anterior temporal lobe, which is involved in social communication, language, of course, but also in more nuanced emotional processing and social, kind of social reasoning. So it's interesting because children and adults on the spectrum have difficulty primarily with social reasoning and nuance and interpreting social behaviors appropriately and then expressing social behaviors appropriately. Comorbidities vary. Up to 50% will meet criteria for intellectual disability. a third, up to a third, can have seizure disorders. So you think that there's just a neurological vulnerability for children born with this developmental disorder. GI disturbances, a lot of food allergies you may have seen, food sensitivities like celiac disease, or they're gluten intolerant or they're casein intolerant. Those substances seem to increase inflammation in the brain, so you'll see a lot of avoidant diets where the parents don't want those kids to be on that. Asthma, upper respiratory, kind of chronic upper respiratory problems, which is also inflammatory. And you'll have kids with autism who, if the parents go off gluten and go off casein, that their mood, their energy, their cognition, they're more engaged with the environment. It's kind of like they get better when that inflammatory state is reduced with environmental changes. The theory about this autism is caused by vaccines, by toxic substances in vaccines, that's been disproven, and the person who claimed that was discredited for ever claiming that was it. So that's unfortunate if a lot of kids then didn't get vaccinated because of that. The chapter on this is really interesting, and they mention different theories of kind of explaining autism spectrum. The theory of mind, you may have heard, and that's the idea that you can see someone and interact with someone and sort of know, for the most part, how they're feeling in the situation, probably what they're thinking, not to a T, of course, but you generally can assume if I do this, the person will probably generally interpret it as something else. Or if that person does X, Y, Z, this is probably what they're thinking. This is probably their intention. Folks with autism have great difficulty intuiting other people's motivations and feelings and thoughts. They have difficulty kind of exporting their inner world and relating it to how other people's inner world might be. Another interesting theory they mention to explain the core features of autism is a weak central coherence model, which is also interesting. We'll talk about that. May as well just move the slide down because that'll be helpful. That people with autism have difficulty sort of generalizing. They have great gifts and great strengths with kind of separating pieces of things, looking at pieces of larger, bigger little systems, like say an engine or a clock or a train. They're very good at figuring out how things work and the different pieces that are distinct. But as far as generalizing or viewing things from the big picture or from a system standpoint, not from the itty-bitty pieces that make up the system, that's a difficulty for them. So they can be really good at working with objects, working with items, working with data, distinctly separate things. Kind of sounds like engineering. Kind of sounds like, I don't know, you just kind of, it makes me think of NASA. Interesting documentary I saw the other day about the Hubble telescope. It's just little tiny things. That's all the telescope is. That's what they're more comfortable. That makes sense to them. They can be very talented with memorization. If they experience something, it is stored and that's it, and it is distinct, and they will remember it. I worked with a guy who, he worked in a mailroom because he had memorized, just with exposure, every address of mail that went through this. I think it was a mailroom at an accounting firm in Birmingham. But he'd memorized the street addresses and which zip code they went with. So he was able to look at an envelope label and know if that address was right, if the address matched the zip code. without error. He was actually more efficient than a computer program the company had bought to try to avoid, mail going to the wrong place. So as far as visuospatial reasoning, how things are different from other things, actual spatial manipulation in 3 dimensions, very talented as far as that goes. Their difficulties are with how things are similar and generalizing one experience in this situation, kind of generalizing that to another situation. If it looks different, then it's totally different, and they can't predict and they can't translate the behavior if it from a sensory standpoint, if it looks and sounds and feels different than it is. So you can imagine how difficult social interactions would be if they have difficulty translating their classroom to the cafeteria. If those seem like just completely unrelated environments, then how are they to know what to say, what to do, what to expect? Because they cannot generalize take from the small to the large. And there's a biological parallel to that. If y'all have read any about the default mode network, it's a network of brain structures. Most of these are frontal, but temporal lobe, frontal lobe, temporal pole in particular. You don't need to know anything more technical than that, but it is brain structures they are activated on a scan. Those structures light up when the person is reasoning, when they're reasoning through some sort of social emotional event, when they're processing emotional information and what they ought to do based on that, when they're trying to connect. Temporal pole, now that's where your hippocampus and your amygdala, your temporal lobe, that's where your hippocampus and your amygdala are so closely. The hippocampus is really the bottom of your temporal lobe. That's memory. Is this familiar or not? Have I been here before? What did I do last time? What worked last time? Excuse me. There is disconnection between those structures. Temporal lobe, emotion processing centers are not connected to executive areas. They're kind of hyper connected to themselves, but they don't connect to other areas. So deliberately processing social emotional information, remembering, last time, let me kind of map what I did last time onto this time. This is probably kind of sort of what's going to happen. The structures you need to do that aren't connected. They're connected, but they're inadequately so. It's kind of like the connection's too weak. So there's a physical map for these symptoms. What was my point? The 2 main symptom clusters with autism spectrum that you will observe when you're working with kids or adults with autism. One of the main ones, they actually combine communication and social interaction. So you'll see these things on the screen right here. This is how things you would expect when you're interacting with them. So for young kids, and the American Academy of Pediatrics recommends screening for autism spectrum disorders at 6, 12, 18, and 24 months. If you find yourself working somewhere that maybe kids and families don't have access to primary care and well baby checks and things, I don't know where you would work in that, really. Some super rural setting. You would want to know that that's the recommendation of the pediatric academy, because by 12 months there should be speech. There should be before a year there should be smiling and laughing and looking at parents and look over there, and they will kind of follow They will follow over. The shared gaze, which is, oh, look at over there, and they know, oh, this person is looking over there, and I'm going to look at over there with them. Seeking out relationships, spontaneous play. For little older kids, remember when we talked about when speech gets internalized, and then you can start using symbols, and you have mental representations of things. If you're working with a kid who's 3 or 4, when fantasy play should be big, and you're wanting to play with other people, and you're kind of mapping your internal world to the outside world, that you won't see that for kids with autism. The stereotyped behavior, which is like the snapping or the rocking, it's just a behavior that is repetitive and seemingly purposeless to the outside world, but it's just them maintaining some sort of sensory stimulation. We shift in a chair when we sit there for too long, we kind of swing our leg, we tap our foot. It's the same concept. You need some sort of stimulation to regulate. And folks with autism spectrum have a different sensory experience, which we mentioned at the bottom of this screen. They may be hyposensitive to some things. They may be hypersensitive to some. So when you're working with kids with autism, you just maintain awareness that, I guess if you're working with a clinic that maybe you see a fair number of kids, you want a variety of sensory stimuli in your office. You would want some soft fuzzy things, some smushy things, some soft or like harder plastic with bumps. You want different light sources, different places to sit, bouncy balls, because they interpret. Another area with altered connectivity is the parietal lobe for these kids and into adulthood. So sensory experience can't be predicted. You can drop a really loud pan and it's like they don't even notice it, or the buzz of an overhead light is intolerable to them. So you just want to be aware that there may be altered sensory experience, and as such, they may try to correct that, like any organism, like any of us would. Well, if I'm kind of hypersensitive, then I may try to just stay away from that, and if I'm hyposensitive, I may try to generate some stimulus on my own with snapping or rocking. It's all an attempt to regulate. An autism spectrum, like any spectrum, it exists with degrees of severity. So children who are on the severe end of the spectrum will be at greater risk for that emotional lability and the potential for self-injury. These may be kids who will bite knuckles, they'll bite their hand, they'll bite their arm. And this is typically when they are very upset. And it's just an attempt to try to regulate. They can't ask for what they want if their language is not, if verbal speech, and some folks with autism on the spectrum, they talk fine. And, folks with Asperger's may talk a lot. And that's why their diagnoses were often missed younger, because they didn't have any of the language delays. They may have actually been hyperverbal and had amazing vocabularies. On the more severe end, there will be significant expressive language deficits. There may be auditory, receptive language deficits. So you can't just rely on talking, on speech. So how are they to ask for what they want? How are they to say, I'm uncomfortable, I need to get out of here, I'm kind of feeling overwhelmed, I would like something to drink, I'm scared because I don't know what's going on, and what's happening, I have no idea. They can't say any of that. And when people get scared and and your fight or flight is activated. Unfortunately, self-injury is a very efficient way to gain some control and bring down that sympathetic excess activation. Self-injury is really good for that. Something else that's good for that is to establish a system, a alternate communication methods. A lot of folks with autism are really efficient with sign language. On the maybe moderate to milder symptom severity, they do well with. That's the next slide. We can talk about it on the next slide, but predictability, and if speech is not an effective means of communication, then you just translate the symbols of speech that are kind of, that's not a tangible thing. You need a tangible, visible, tactile means of communication, because their brains interact with the world better, not necessarily through this ethereal symbolic speech, but with visual symbols, with pictures, a Dynavox, different kinds of communication devices, and with sign language. So if you can translate it to the physical, to a three-dimensional, then that will allow for communication, and it can be, with support, can be effective. And then a lot of the more concerning behaviors go down significantly, because it's just about getting their needs met. We have a limited window of when language can be learned real well, so that's why it's so important to identify kids as young as you can, so that you can try to instill other means of communication that are compatible with them. Sabina's saying there's a video documentary, New York Times. Oh, that's interesting. Communicated using Disney films. I have not seen that, but I would be interested to. There's a lot of information on this slide that's really just, we don't need to talk a tremendous amount about it. Screening, yeah, 6, 12, 18, 24 months. No verbalization at all by age 2. There's screenings, tons of screening instruments for this. But if you know what you're looking for, the social communication difficulties and the stereotyped, rigid, repetitive behaviors. And there's a lot of comorbidity with obsessive compulsive disorder for folks with autism, anxiety disorders in particular. So in the presence of comorbidities, you would treat the comorbidities like you would independently. You may have to adjust doses depending on how the patients tolerate it, but the main comorbidities are going to be some form of anxiety disorder, and you'll be limited based on the patient's their ability to report, but you can expect some increased anxiety in social situations, distress with changes, new environments, and compulsive behaviors that are very, very, very repetitive. So with SSRIs, SSRIs can be really helpful in reducing just sort of your global distress when it's due to anxiety, when it's due to depression or irritability. Those can be very helpful. Like with anything, you probably want to start low. You want to go with an SSRI. Zoloft is great because it gives you depression, anxiety, and OCD coverage. And with young kids, sertraline is, you're looking at things that have been proven safe. So that would be a good way to go. Lexapro is always usually really well tolerated as well. Abilify and Risperdal more recently have gotten FDA indications for the irritability associated with autism. There is no medication for the core symptoms of autism. There are medications that can reduce distress upon transitions, that can reduce the intensity with which compulsive behaviors are performed, and can reduce self-injury and that mood lability and essentially the magnitude of distress that they can experience and the potential for injury. Risperdal and Abilify are the two meds indicated for that, to reduce essentially the emotional dysregulation that can be exhibited by folks with autism. The younger the child, the lower you would dose, like 0.25 of Risperdal, 2.5 of Abilify. I haven't seen anything to say that one is necessarily better than the other. Abilify will be less sedating than the Risperdal will be. Risperdal may be better for that purpose because it can be a little more sedating and more calming. You're still going to need to watch out for the metabolic disturbances of any of these. But Risperdal and Abilify are the two you're going to see the most for folks with autism. And what you're trying to reduce is self-injury and the mood lability. If the child has, and again, if they meet criteria for hyperactivity, for ADHD, hyperactive, impulsive type, then you would treat that. Remember, a lot of kids with autism have comorbid seizure disorders. That would have to be treated. We would not treat that. A neurologist would want to manage the seizure medications, wanting to practice within the realm of your experience. So the main things that you'll see kids with autism on is going to be one of these atypicals and an SSRI. That's going to be probably the most common things, medications that you would see for them. It can really, really help them stay engaged in the behavior support and the communication skills training. So important to know referral sources in your area. You want to know the milestones. You have some screening measures, and Thapar and Pine mentioned several. The MCHAT's easy. But more than medicine with autism spectrum is going to be behavioral support, communication, assisting them with communication training, and helping the families structure the environment so that the child can interact the most productively. But you may be called on to try to help with some of the behavioral disturbances, the OCD kinds of behaviors. And we got great medicines for that, which is really good. Any questions about, and really we're referring more to moderate to severe autism spectrum, would need the medicines like the atypicals. Otherwise, this is largely behaviorally managed. Support and structure and skill building. And pull this up. Voila. Okay. Switching gears to child adolescent anxiety disorders that can present disorders that can present in childhood. ADHD has to. Autism spectrum disorders have to. That is from birth. ADHD is from birth. Anxiety may be from birth, may not be, but there's a better chance that it'll present in childhood than other disorders will present in childhood. If you work outpatient, then somebody had mentioned, was it, who said that? Somebody had said you were seeing, that was Sabina. When you said the younger kids presented more anxious and then the older ones presented, when you say younger, kind of what age range were you meaning, Sabina? Like 5? Yeah. Separation anxiety. Separation anxiety is going to be prominent in that kind of that sort of age, that young. As a group, it's the most common disorder seen in children, as high as 25%. Yikes. That's a bunch. Is this going to result in kids needing to go to the hospital? Probably not. It contributes to something else that may result in that. But just because it's not, this is more of an internalizing, these kids are suffering and they may be suffering silently. So we just want to be sure to consider and be alert to this because of the higher frequency. It's interesting because it's gender equal, sex equal, until adolescence when girls present more than boys. There's a separation there that you'll see higher rates of anxiety disorders and depression for girls once you hit puberty. These are just some other thoughts. Anxiety is not necessarily a bad thing unless it causes impairment because the child doesn't want to go to school or the child is, having crying spells because they're getting so upset about some kind of change in schedule or they did something bad or they embarrassed themselves at school. So what does the anxiety look like? It can be clinically significant distress. The child is just, the child is in distress. They are crying really easy. Maybe they still go to school, but it's a struggle, and it's clear that they're uncomfortable, that they're saying, I get stomach aches every time I have to go from to my grandparents' house, or when I'm getting back from my grandparents' house, or I'm just having headaches every day and I don't want to go to school. That's significant distress. That's more than you would expect. That's more than just normal anxiety. And some of the behaviors you may see is a lot of just trying to avoid things. They just would rather not do new things. Anything new, don't want it. Just going to stick to my groove. They may cry pretty easily. So it's as though they have large emotional responses that they don't know what to do with. Or maybe they haven't seen adults manage emotions, and their parents haven't scaffolded them and walked them through how to calm yourself down. Oh, it's going to be okay. Let's come over here. Let's take some deep breaths. The criteria for anxiety disorders that present in kids are identical. The criteria technically are the same. Generalized anxiety is worrying about all sorts of things for at least 6 months. What you'll see more, and I'm sure y'all see, is somatic complaints in kids, headaches, stomach aches, just don't feel good. Some of the ways these kids will often be They worry about being on time. They may be clock watchers. They get real upset if they think they're going to be late. They tend to go into new situations predicting a negative outcome, not any particular negative outcome, but just something bad's going to happen. This isn't going to go well. People aren't going to like me. I'm going to fail my test. It's just sort of general. If it's new and I get anxious, then something bad's going to happen. So if you have parents bringing kids in because the child keeps complaining of headaches and stomach aches, and especially if there was if it seems to get worse around changes, or you always, especially with kids, because while this is one of the more common disorders, not to say that it is common, but of the psychiatric disorders, anxieties matches up with kids better than schizophrenia or bipolar disorder. You always want to do a history. You always have to interview the parents alone. You interview the child alone. You interview the parents alone to listen for stressors and changes, because the odds are very good that there is some environmental component contributing to this. Or parents are volatile, or parents, they don't handle anxiety real well themselves. So there are parenting interventions more than medicine to teach the child how to reduce their anxiety on their own. The most common, so GAD is kids, they're just generally worried about anything and everything for an extended period of time. They probably have an anxious parent too. That would be one thing to ask about. Separation anxiety is going to be the most common of the anxiety disorders. It's probably going to be the most common. And those are the symptoms there for you to commit to memory. But this is going to be anxiety that is more specific to, I don't want to leave my parents. I don't want to leave my house. I am worried about my caregivers. I don't want to go to camp. I went to a friend's house, but no, I'd like you to come get me before bedtime because I want to be reattached to my primary caregivers. Don't want to be alone. Those physical complaints. And kids can become so upset, so worked up that they will actually throw up, or they'll start, they will cry so hard that they start coughing and they might throw up. And that's significant distress. That's beyond what you would expect for a 5 or 6 or 7-year-old related to being separated from their primary caregiver. But again, the more or less 4% of kids are going to meet criteria for that. I don't want to go to school. I want to come home from school as soon as I get there. The great thing about anxiety disorders, even when they present young, when there is more than likely some environmental component contributing to this, related to parent anxiety. Do the parents, and you will learn this from interacting with the parents, from watching the parents in the office, from getting to know them a little bit better, that they have an anxiety disorder themselves. They're unnecessarily apprehensive about new situations, because what that communicates is that new situations are dangerous. For parents to be kind of smothering and overprotective and not let the child go out and see that they really are. New things aren't dangerous and bad. If the parents they try to be super duper controlling, they need to be on a schedule if anything's out of place, or do the parents communicate that that there are threats in the environment well beyond their control, well, then the child is going to pick up on that and just be generally anxious, try to apply that to something. So they'll worry about everything because everything might be dangerous or a threat. Plus, you have we talk about parental warmth and responsiveness. Childhood adversity or adverse childhood experiences change the hormonal environment in the body, and they change how brain structures develop and connect with each other. So you want to talk about the necessity of a social history, in particular when you're working with kids. There's lists of adverse childhood events. I'm trying to think if SADC includes those. But things that you would want to ask for, in particular, for kids presenting with anxiety or depressive symptoms, you want to ask about trauma, adverse events. These are just behavioral kinds of things here. We're not at medicines yet, because there are no medicines for anxiety disorders for children. But what can happen is you have parents who don't have real good coping skills themselves, or parents who overprotect, parents who kind of set up an environment that the child is going to be under great stress, but not know how to handle anxiety or anger or frustration or depression or any of those things. Make sure the parents know coping skills. There are manualized effective anxiety disorder treatment manuals. Coping Cat is one. I think the Par & Pine may even mention that. I have a copy. It's very helpful for younger kids, maybe 5 to 10 or 10 to 12. I kind of lose people at 12 because it's you have a cat who teaches you how to be aware of anxiety in your body and how to identify emotions and express needs and express sadness, anger, the emotions that you learn through the course of that. But it's most often just getting the family on board with the fact that the child has this need and getting the family more aware of what they're doing to contribute to it. Having the parents practice anxiety management skills, counting, deep breathing, an automatic thought record, having the parents practice that with the child is probably as helpful. Having the parents attend to him or her and connect and be present and be responsive and be sensitive is probably as helpful as any skills the child learns in the process anyway. So you start with this. How's the family system contributing to this? Is the family system necessitating the child's anxiety as well? Is it a real volatile, no communication, arguing, no routines, no schedules, no normal bedtime, no that? Of course the child is in distress, of course. If those kinds of behavioral interventions don't help, I mean, you can get a little pinwheel and use that to help the child practice deep breathing. There's yoga for anxiety management for kids, because a big part of it is getting them more aware of the internal sensations associated with anxiety, to be aware of when their anxiety is increasing, and then, okay, I need to do something to calm myself down. I've reached that level, which is how adults do it, but they may not have had an adult show them how to do that. There are You'll see a lot of times for kids, Vistaril will be used for PRN anxiety or for scheduled. Say these are helpful, but they're still kind of breakthrough times, like when they're needing to go to school, needing to do something unusual. This is a high stress situation. Vistaril can be used. You can see Buspar used. Some, we're kind of staying away from SSRIs necessarily, but you'll see probably those are the main ones. Maybe Benadryl at night, especially if they're anxious in the evenings. Vistaril during the day, Buspar during the day. If the child is still having distress or impairment, then you would go with an SSRI. Prozac and Zoloft and Paxil have all shown benefits for reducing anxiety for kids. Now these aren't FDA indicated, so that's something you're prescribing off-label at this point. But Prozac and Lexapro have indications for depression in kids as young as 9. Zoloft has an indication for OCD for kids 7 and up. So you just think, if this is a young child, 5 or 6 or so, and the child is in such distress and they just cannot manage themselves for transitions or changes or going to school. If, say, they have regular doctor's appointments that they have to go to that are difficult for them, Zoloft would probably be the best place to start if you have to go to this level. CBT first, coping skills, kind of PRN, Vistaril. Next stop would be 12.5 or 25 milligrams of Zoloft, because it's FDA indicated to be safe for kids 7 and up for OCD. So, medicate some of the parents too. Sabina is saying there are, I don't know of any interventions you could do for a 5 or 6 or 9 or adolescent maybe. But if the environment perpetuates inconsistency and volatility and just emotion dysregulation, or the parents have their own stuff, it will be really difficult. I don't want to say impossible to evoke a significant lasting change in behavior or symptoms for the child, because they are just absorbing what the environment is given to them. You have. And that's why it's family education with CBT, and teach the parents as you go if you really want. Because the kid will see you for 20 minutes once every 2 months, and they're with their parents the rest of the time. There are some medicines that can be helpful in reducing it, but this is really a skills deficit that has to be addressed, and an environmental deficit. What I'd like to do, let's do this next time. We're going to talk about AIR next time, because what I'd like to do this evening is cover depression so that we don't have to do it next week. This will be quick. Depression, like we talked about, girls, there's a separation more prevalent in adolescent girls and adolescent boys, but prior to that, it's really about equal. Up to 25% of adolescents, that's probably a little excessive.
What? No, I said a lecture.
I think somewhere in the neighborhood of 1 out of 20 is probably more accurate, the prevalence of depression in you will find some sources that say, yeah, 25% of adolescents are going to, at some point, will meet criteria for this, but that's at some point. You're thinking maybe more like 5%. So significant enough to monitor for, but it's not like this is 50% of all kids. If they have a depressed parent, if they have a parent who uses alcohol excessively, if they have a history of adverse childhood events, then all of those things greatly increase the risk of depression. And what they see physically in depressed kids and adolescents is an internal inflammatory state, as though depression, and they don't say direction, the directional, does the depression cause the inflammation, or does the inflammatory state cause the depression? But we know, especially with PTSD, that inflammation, which is the result of the trauma, the result of PTSD, significantly increases risk of depression. It's like your body is, oh, this is a stress. I've been too stressed for too long. I have to go into conservation mode now because I can't escape whatever the stressor is. So let me just go into conserve mode. And that's what you see. Energy, mood, interest, it all declines. Folks with depression, and that's what you see, there's elevated serum cortisol. There's too much cortisol. There's too much stress. Their body is indicating that it's under stress. Inflammatory chemicals. There it is, though they are not depressed, but suppressed, even in a physiological state. Which would make sense if you have a depressed, unavailable parent. If there's significant substance use occurring in the home, you can see how that would communicate to be experienced as trauma or stress. Primary feature, it's the exact same. 2 weeks, depressed or down, loss of interest for 2 weeks. That's technically the criteria. But for younger kids, come on now. This may look more like failure to achieve weight. It gets to be, they kind of stunt, they quit meeting milestones, they start pulling back from things they used to do. The whole guilt, worthlessness, they may describe themselves as nobody likes me, I'm unlovable, I'm useless, I should run away. But primary feature is the same as it is in adults. It's just going to look different. That in kids who are 5, 6, 7, 8, again, somatic complaints. They lack the ability to use more complex, abstract words, feeling words. So it'll come off as, I feel tired, I feel bad, I have headaches, and with younger kids, really kind of irritable. I don't want. Irritable. And irritability in children and adolescents, we think, oh, well, mania, they can be irritable. True. There's activity differences as well with mania. But irritability, when you see that in kids, you think depression before you think mania. And these are episodes that last 2 weeks. This isn't all day, every day for years. That's something else. And it is irritability that comes and goes, is there for at least 2 weeks. And on average, a depressive episode is going to last 3 to 6 months. So not for years on end. But it's irritability. I don't want. Ooh, that was a good long. Thorough history. Yeah, Kelly's talking about some stuff that we're going to talk about in just a little bit. When you're working with kids who present significantly more irritable, despondent, I don't care, I don't want to do anything, I'm touchy. That's in their 10. That is significantly younger than the average age of onset. So this child has some sort of neurological vulnerability, there's no telling what it is, because that is unusual.
No, I'm good. I can't even do much.
So you maintain in the possibility of your differential that this may end up being bipolar disorder. It may. But if you have a family history of depression, if you have uh, any of those risk factors for depression, uh, adverse child event, substance, parent with depression, you may lean more toward a depression as your primary diagnosis than mania, unless you have a family history of someone with bipolar disorder, um, or any sort of euphoria, any sort of period of increased mood or activity, which you don't see with depression. So irritable youngsters, 5, 6, 7, 8, as you get more toward adolescence, you may not see irritability as much. It may present as, well, I don't care anymore, and withdrawal from school, grades drop, don't want to do anything, and substance use is a huge cue for adolescents that there is a depressive disorder occurring. So you got to screen for that. Um, and again, for depression, there's not been any sort of elevated, euphoric, silly, goofy, not sleeping as much, real distractible. If those are the symptoms that have also been in the picture at some point, where there's been a period of time where, just they're really up a lot and just laughing a lot and silly and goofy and real distractible and losing things and forgetting things and kind of impulsive, and then that went away and now there's just this irritability that's hanging around, then, like Kelly's saying, that isn't how depression presents for kids. Family history of mania, that would be a concern. Plus depression that presents younger, that's real low energy, which is not psychomotor agitation, but depression that presents late teens, low energy, sleeping a lot, kind of comes with hallucinations, or with adolescents, it's more going to be, they start thinking paranoid, people are changing. I don't think my pills are my pills. I don't think, I wonder sometimes if my parents are putting anything in my food, or if they're listening through that paranoia, sleeping too much, no energy. That gets you more concerned for this may be bipolar depression that will eventually present as manic. So whenever if people get depressed and they're not sleeping versus they get depressed and they're sleeping a lot and they have no energy and they just don't want to do anything, that's kind of a crude litmus test for this may be more unipolar, not sleeping, kind of antsy, irritable, versus no energy, sleeping too much. Depending on family history, if family history is pointing you, or it's that low energy, sleeping too much, there's some paranoia creeping in, adolescent, uncle had mania, uncle was on lithium, it would behoove you to treat that depressive episode with a mood stabilizer as opposed to an antidepressant, because that's cueing you that this is more likely genetically and present and clinically to be a bipolar depression. But if there is no family history, the safest thing would be to start an SSRI, educate the family about the risk that in a few cases, SSRIs can induce insomnia and excess activity in kids. So you tell the parents, if you see this, to let you know, hold the medicine and let you know. And then you would more strongly consider that this may be a bipolar depression. These medicines, Prozac and Lexapro, actually have FDA indications for depression in children and adolescents. Zoloft, Lexapro seem really great. In trials, they don't have indications. Celexa, I'm sorry, not Lexapro. They don't have indications, but they seem to be helpful. You'll see Effexor used as well. But you've ruled out risk that this is actually a bipolar depression. The child meets criteria. You would refer them to counseling because people do better with both, significantly better with an SSRI and therapy. You educate the parents about the risk of activation, which is small, but it's possible. You just want the parents to know that's not normal and that they need to call you. And the risk of increasing suicidal ideation or an actual suicide attempt, which happens in a very, very, very small number, very small percentage of kids who were ever exposed to SSRIs. And I think that was Paxil was the culprit of that anyway. Because suicide is a risk for adolescents. It's the third leading cause of death in adolescents. Firearms are the number one. Hanging is number two. For women, for adolescent girls, ingestion, so poisoning. There is a risk of harm to the person if you don't treat it. Irritability, you think depression. Because studies show that kids and adolescents who present primarily irritable, if you track them out into adulthood, they're much more likely to end up with depression than they are with bipolar disorder. But you have those few little cues that might say, hey, if I treat this child with an SSRI and I don't get a response, or they become even more irritable or more active, then that says, ooh, that tells me that a mood stabilizer is going to be what we need to do. But the odds are just better that it's depression in the absence of some sort of real close family history of bipolar disorder. If the child has a history of non-suicidal self-injury, that increases the risk of suicide. If they're thinking of suicide, if they have a previous attempt, and the treatment is really helpful, and one of these medicines, so somebody's asking a medicine question. If the child says they're doing better, and the parents say it's good, but the child has insomnia. If insomnia is the only thing, insomnia wouldn't make me think, ooh, this might be hypomania. There would need to be irritability and distractibility and euphoria and kind of just silly, goofy, impulsive, unusual behaviors. I would keep the SSRI and I would try to add something to help them sleep. If insomnia was the only thing that changed. But the mood is better, but there's no behaviors of concern. So yeah, but that's a really good point, because SSRIs, pick one that's FDA indicated first. It's just the smartest thing to do. Zoloft, I like Zoloft for younger kids, 5, 6, 7, 8, those kind of ages. But Prozac has been probably the most, Prozac's just the most researched SSRI for anybody ever. So you could justify picking that one. Sleep hygiene, yeah, Kelly, definitely. You want to be sure there's a bedtime and they're not having a slushie and 3 Pop-Tarts for a snack after dinner. And yeah, definitely melatonin first. I would try that first. Then I might try Benadryl. You could do mirtazapine. You could do, it just depends on how bad the insomnia is and kind of what response you would get to the melatonin. But if suddenly their sleep is all messed up and it wasn't before, I would think, well, that's unusual. And you would monitor more closely you would educate the parents, say, these are the symptoms of mania. I just want you to watch for these things. But if the SSRIs don't work, and you should see a benefit in a couple of weeks, they should be less irritable. They should be a little more engaged in family. They should be more more verbal, more willing to talk to you, more willing to talk to parents. There should be a behavioral indication. If not in 2 weeks, then you could try a second FDA indicated SSRI, or you could switch to Effexor. You could try bupropion. You could try mirtazapine. Some parents don't want to do medicines. You could recommend, there's not convincing data about omega-3s. You could recommend folate supplementation for parents who don't want to do actual medicines. Side effects are the same. But really important to watch for at med initiation or at dose changes for a few weeks after that, to watch for my activity's up, my distractibility's up, I'm talking a lot, I'm hyperactive, I'm texting all the time, I'm staying up too late. After initiation and dose changes, you just educate the parents. And the possibility of suicidal ideation increasing can occur with younger patients, meaning anybody under 25, but that's usually going to be within the first month of initiating the medicine. So it's not necessarily a forever increase, but you educate the parents about those two things before you start a SSRI. So omega-3s are only approved therapy for kids with bipolar symptoms under 7. You're not going to hurt anybody with omega-3s. With depression in particular, the what do you call it? The jury's out. Yeah, what's that omega-3 medicine? Equasin? Am I making that up? There's some, I want to say that's what it is, being used for augmentation of ADHD, kind of irritability associated with ADHD. So depression is a distinct, you can say when it started, you can say when it stopped. These are distinct episodes that can present in kids who have family histories, who have risks of this. Adverse childhood events. They get better quicker when they're identified, and that may, their symptoms, their depression may look more like somatic complaints, headache, stomachache, I'm hurting all over, kind of random pain. It should go away on its own. These don't last for years and years and years. When we talk about irritability with explosive anger that is persistent for 12 months or more, that's when we're getting into something really different. So what we're going to talk about next week, we're going to pick up with bipolar disorder, really early onset bipolar disorder, and how that is similar but different from a newer disorder we have, the disruptive mood dysregulation. And we'll do ODD and conduct disorder just for a minute, because probably the main things that get kids inpatient treatment would be some combination, some sort of behavioral, other than, I guess, really early onset psychosis, bipolar disorder, disruptive mood. So don't be scared, don't be hesitant to prescribe these kinds of medicines to kids who need it, that the risk factors and the history and the presentation warrants it. These medicines can be really, really helpful. Depression, statistically more likely to be than bipolar disorder, but in the instance that you don't get a response from the SSRI, or there's some other risk factors, that make you think more mania, bipolar depression, then a mood stabilizer would be appropriate in that case. More than likely, one of the atypical, an atypical antipsychotic. But we'll talk about that a little bit next time. So when you're working with preceptors, just ask them, pick their brains as best you can. Those of you who are working with preceptors who see kids in an outpatient setting. When you're talking about anxiety, medicine prescribing, unipolar depression, medicine prescribing. So after a 20-minute delay getting started, I do appreciate y'all, your patience with that. We're going to pause it right here, unless there's any last minute questions. I appreciate your questions, Kelly. They're all very good. And we'll pick up with bipolar assessment and treatment next time. Any, did you have any commercials, Dr. Fogger? I don't have any.
No, just about the question with therapy, about how does that need to go in Typhon, but
Oh, yes. Thank you. Yeah, you can get up to 30 hours of patient simulation, and if you're sitting with a therapist, then go ahead and enter those hours, even if you have to break up a day, 6 hours with the preceptor, 2 hours with the therapist, put it in under simulation. And please don't sign up for the two-factor authentication.
so that's how you're logging them is under simulation, even though they're not simulation?
It's because it's, yes, that is what we're doing.
We ought to be able to get them to create a spot called therapy.
Okay. We can check on that.
Yeah, because it's not really simulation, and therapy is considerably different than where our. I didn't see that. Hang on for a second.
That has been approved. Where are the instructions to add a preceptor? Oh, adding a preceptor. If you go, I believe that, look in the discussion posts. Look in the discussion post in 686. That's a common question that you can go into Typhon and go under frequently asked questions. And one of the things that pops up is, how do I add a preceptor? So you could go to Typhon, or I think there's an explanation as well in the discussion. If you're away from your preceptor and therapy to reduce number of patients. Right. We just want you to distinguish patients you're seeing with your preceptor doing med management versus patients you're seeing in a different treatment modality. So that's all that is. But those are good questions. So thank you for asking them. And any other questions? Well, I will go ahead and stop the recording, ladies and gentlemen.